Good afternoon from the Malaria Consortium London office. I'm Dr. James Tibendarana, the Technical Director with Malaria Consortium. I welcome you to this webinar that we're hosting. We have some very interesting presentations and very reputable and eminent scientists and implementers who will be sharing some of their experience on this very important topic on the drug-based prevention of malaria in pregnancy. As you know, the WHO recommendation, the first recommendation was made in 2007. And 12 years later, we are still having suboptimal implementation of intermittent preventive treatment in pregnancy. And I think the World Malaria Report in 2018 said that amongst 33 African countries that reported IPTp coverage, and that was in 2017, an estimated 52% of eligible pregnant women received the recommended 3 or more doses of IPTp. So 12 years later and 7 years later after a revised recommendation in 2012, we are still struggling to achieve coverage that provides the option to pregnant women. And so hopefully in this conversation and this dialogue, we will discuss the future of drug-based prevention of malaria in pregnancy and some of the issues that we have experienced from our implementation and from our research as researchers in this space and implementers. So thank you very much, and we'll start off with a series of presentations, starting with Professor Rose McGready from Shoklo Malaria Research Unit. We'll be talking about malaria and pregnancy in Asia. The second presentation will be Dr. Julie Gutman, CDC. She'll give an overview of malaria and pregnancy in Africa. And then Craig Bonnington will talk about IPTp in HIV-positive mothers. And then Dr. Anthony Nuwa was a case study from some work in Uganda. We will have periods where we'll be answering questions. So please submit through the web chat to the host, and we will articulate those questions. Some of the questions we might not be able to answer, we will try and follow up to ensure that we can provide at least some verbal answers via email. It's an interactive session, so please invite you to participate and enjoy the conversation. Okay, Professor Rose, over to you.
Thank you, James. Thank you very much, and well done for everyone for joining wherever you are in the world. We're kicking off with malaria in pregnancy in Asia. And I'm speaking from Shoklo Malaria Research Unit on the Thai-Myanmar border. Next slide, please. And I've been asked to speak about the challenges in this region, to give a little bit of background on the work that we do here, how malaria affects the pregnancy, the type of challenges, and some information on drugs in first trimester and what we're planning in the greater Mekong sub-region. Next slide. So just to remember that we're talking about something that affects the life course forever. So malaria in pregnancy and antimalarials are going to change that child's life, and that will affect the economy of their country. It seems a small disease, but it has a very big effect. And most of the work done on malaria in pregnancy has mostly been conducted at delivery, which is providing a snapshot. It's not really telling us about the whole story of malaria in pregnancy. And when we look at pregnancy outcomes, we actually have multiple factors to control for. Next slide. This is from the Malaria Atlas project. You can access it yourself. On the left-hand side, it's showing falciparum in 2005 and 2007, and we can see a decrease in incidence. White is good. White means no malaria. Same for Vivax, although the change is far less marked than what we see for falciparum. Next slide. And SMRU, Shoklo Malaria Research Unit, we're based on the western border of Thailand with Burma, and we have worked with marginalised populations for more than 30 years in refugee camps or migrants, mostly economic migrants. And this part of the world's had a significant problem with drug resistance, and most of our work has been chasing that drug resistance, trying to come up with a 3-day treatment for pregnant women to treat malaria, and we're still not there. Next slide. So this all kicked off more than 30 years ago, when MSF was the main health provider to refugees on the border, and that the first left-hand bar, which is labelled prior year, that was the maternal mortality from malaria alone, 1,000 per 100,000, or 1% of all pregnant women died from severe malaria. And the remainder of the bars all cause maternal mortality. So in 1986, early detection and treatment of all pregnant women was introduced. There was no effective drug for prevention of malaria, and the only alternative, which I think WHO describes as case management, we went for a very different approach, which was active detection and treatment, and that data has been collected for more than 30 years now. That's the only thing that we've found. That's okay, next slide, thank you. That's the only thing that we found does reduce maternal mortality in this setting very effectively. So active detection and treatment, you can see the lady on the lower left-hand corner getting her slide done. So a lot of investment in quality control of those malaria slides so that they're accurately read. Every technician has a QC program run every 3 to 6 months. Next slide. And moving on to what malaria does to the fetus. These are risk-hazard ratios, and we have falciparum and Vivax. This slide's talking about fetal loss, so miscarriage and stillbirth. And at SMRU, all episodes of malaria are treated, and it's very clear that even treated malaria results in fetal loss. Next slide. And this loss is much worse when malaria is symptomatic, but it still occurs even when malaria is asymptomatic. Next slide. And most of the early loss in the first and second trimester, that's driven by miscarriage, and that becomes much worse when there's recurrence of malaria. For example, the ACT doesn't work, or quinine doesn't work, or there's a recurrence of Vivax mostly from the liver stage. Next slide. And when we've examined the fetal losses from over 30 years and more than 70,000 pregnancies, we find that those stillbirths are antepartum loss. It's rarely a death during labour, but that's probably because of the very active detection and treatment program that we run. Next slide. So small for gestational age, or being born too small. And this has really replaced low birth weight, the outcome of low birth weight, because small for gestational age accounts for the gestation and the sex of the infant. So you need accurate gestational age assessment, and we introduced ultrasound in 2001 on the border, and local staff are trained how to do that. And this, sorry, not yet. This slide shows the terrible toll of malaria. So a single episode is associated with small for gestational age, but multiple episodes, particularly for Vivax, the odds ratio increases markedly with increasing episodes. So having an effective drug for treatment is very important, but what you would really like is an effective drug for prevention, which we don't have due to drug resistance. Next slide. And so this was looking at the timing of the infection. So any infection after 12 weeks for falciparum and after 20 weeks for Vivax is associated with small for gestational age. Next slide. Preterm birth is also related to the timing of infection, and if we have malaria detected and treated from 24 weeks, we can see very preterm births. So, yes. And if we have, sorry, next slide. And if the malaria is detected after 24 weeks, we also see late preterm births. And the colours have changed a bit here. So falciparum's in the orange dots and Vivax in blue. And this is just showing small for gestational age again, but that whether the malaria is asymptomatic on the left or symptomatic, we still see the problem of small for gestational age. And asymptomatic is commonly described for malaria in Africa and often thought of benign, but for the fetus, it is not benign. Next slide. There's a lot we don't know about antimalarials in Southeast Asia, and if we want to move towards elimination of Vivax, we need to think about how we use drugs such as primaquine or tafenoquine. Primaquine is not safe to give in pregnancy, and the question is, when is it safe to give after pregnancy? The only study that's been done was done on the border, and primaquine was given to mums who had repeat Vivax infection when the child was more than 1 month of age. And there's actually very low levels of primaquine found in breast milk, mature breast milk, but we're not sure about colostrum. That's that dark yellow milk that you see in the picture on the left-hand bottle. So that study needs to be done. If you're treating and detecting Vivax, you don't want it, and a woman has it in pregnancy, she really does need to have eradication of the liver stage to prevent preterm birth, small for gestation in the next pregnancy. So working out the best time to give it is very important. Next slide. So I was asked to talk about some of the challenges, but I don't think these are unique to Southeast Asia. We have a problem worldwide of counterfeit substandard drugs. A lot of the larger seizures have involved antimalarials. Dr. Paul Newton, he's pictured on the right there, and there's a link to a interview about that work. We all need to be aware, and if possible, find ways to detect drugs, antimalarial quality before we purchase the drug. And the inexorable spread of resistance is really an issue for the artemisinin derivatives. Asia's facing significant problems with rising rates of MDR resistance to the stage that on the border, every antimalarial we've ever used, we've lost it to resistance. And with the loss of ACT and nothing in the pipeline, there was very little choice except to go for trying to eliminate malaria. So that's what's happening. But the very big worry is if artemisinin resistance reaches Africa, as all resistance has in the past, we really are in very big trouble for what we should do next. So the pharmacokinetic, we've done about 10 studies on the pharmacokinetics of antimalarials in pregnancy. And for many antimalarials, the drug concentration is lower during pregnancy. And this can be a problem for drugs that have a partner drug, where you might need to increase the concentration, might need to increase the one of the drugs but not the other ones, but it comes in a fixed combination. So it becomes quite difficult. Doing studies where we realize the correct concentration. So doing pharmacokinetic studies is very important, especially when we see all the data so far on Coartem, which is the most widely used antimalarial for pregnant women in Africa, says very clearly that we are underdosing women, which is a really good way to lose the drug. Next slide. So this is much more focused on Asia. So we haven't had a good success from bed nets, and that's mostly due to the behavior of the vector, which has longer biting hours than when we go under our nets. We have had no chemoprophylaxis for more than 5 decades. We're trying very hard to find an efficacious treatment, and that goes also for Vivax malaria. And most of what I've spoken about here today has been concentrated on the work on the border, but other strong work on pregnancies come from Neeru Singh's group in India, and Dr. Rini, who's based in West Papua, and also work from Papua New Guinea. But the same problem, and even worse problems, are seen in West Papua with much more drug-resistant Vivax infections. So currently on the border, this pattern of resistance means that if we see a pregnant woman or any patient, because the treatment's the same, with severe or hyper infection, we will treat with artemisinin and quinine, because by the time we work out that it's an artemisinin resistant infection, we've lost the patient, or the patient's become much more sick and is therefore harder to treat. We have very low efficacy with Coartem. It's not our first line treatment. For the moment, we're using dihydropaparaquine, but we're seeing that, I'll show you in a minute, we're not actually seeing much falciparum at the moment. We also need to remember that when we use chloroquine, it just might not work. The first case of chloroquine-resistant Vivax on the border was described from our unit. And the other problem we have is very high rates of G6PD deficiency, which creates a problem for when we go to use Primaquine for radical cure. Next slide. So on the left is data from the Malaria Elimination Task Force, which has put early diagnosis and treatment in very, very small villages. And having the treatment close to the patient has changed the face of malaria in this area. Malaria is reduced radically. We haven't seen a falciparum in Vivax for maybe more than 4 years now. And we're also seeing a decrease in Vivax with that. So the process of trying to eliminate malaria is having a very good effect on malaria in pregnancy, although the program doesn't target pregnant women, it targets the general population. Next slide, please. So work on first trimester antimalarials has come from two sources, Asia and Africa, principally Asia and Africa. And we've compared it to the only recommended antimalarial, which is quinine. And it's clear that artemisinin are as safe, if not better, than quinine in the first trimester. And why would they be better? The reason is that they are better tolerated and more likely to be complied with than a 7-day course of quinine. The fears that the problem of fetal resorption that was first described in animals would be seen in humans is not seen, and that's mostly related to the way humans develop red cells compared to rats, rodents and monkeys, and the very short treatment course that we use when we give artemisinin derivatives. Next slide. So as we're thinking about first trimester ACTs, we do need to think about which ACTs have a safe profile for trimester 1. I've left off amodiaquin, which goes in the not safe group. Most of our not safe group are antifolate drugs and can't be used in first trimester, and that presents a huge problem for women in Africa because we know that the effects that we see on pregnancy loss, on the change in immunity, in abnormal placentation. So the changes that occur in the placenta when you're infected early in pregnancy are irreversible. So finding an antimalarial that prevents malaria in pregnancy, early in pregnancy, or even before a pregnant woman conceives, is very important. The other problem that we have in Asia is that we're moving, the studies on triple ACTs are moving along rapidly, and some studies are changing to quadruple ACTs in areas with severe multi-drug resistant falciparum. Next slide. So, in summary, artemisinins really are the most efficacious antimalarial we have, and they really should be used in pregnant women. And if they're not being used in your area, you should make efforts to see this change happen. Artemisinins are not associated with increased rates of miscarriage, stillbirth or congenital abnormality, and no ACT outperforms another ACT. Quinine really has lower efficacy and tolerability. The WHO policy on quinine needs to change. It's outdated, and pregnant women are going to do better if their episode of malaria is treated completely the best we can with an ACT. The prevention of malaria is challenged by resistance to SP. We need to think about different antimalarials. We need to think of new ideas. So should we be thinking of preconceptual studies that we get women in a better health before they become pregnant? We really need to optimize the antimalarials that we have, especially coartem. We've just finished a study on 5 tablets twice a day for 4 days, which has not improved the efficacy of coartem. It's still around just over 80%. It's not good enough to deploy. And finally, when we want to prevent malaria, it's really clear that a single infection is harmful. We need to prevent malaria, and that means no parasites during pregnancy and no parasites in the placenta. So that means adequate protective concentrations of the drug throughout pregnancy, and we really need new ideas. Maybe we can have a mefloquine patch like we use for hormonal contraceptives. We really need to be thinking outside the box because the evidence on SP is not reassuring at all. Thank you. I think, am I finished? Thank you. Thank you, everyone.
Thank you very much, Rose, for that very interesting and sort of stimulating presentation. And a couple of questions have already been communicated regarding the use of artemisinin in the first trimester of pregnancy.
That is a great question. Ask them.
It's something legal. We don't know.
So,
Yes, Julie.
Go ahead, Rose.
well, there's combined data from Asia and Africa says that the ACTs are as safe, if not safer than quinine. There is no randomized control trial, and nobody is prepared to fund it, I suspect. To show, if your aim is to show a difference in congenital abnormality, then you need a very large sample size, approximately 10,000, because the chance of the abnormality is so small. So the likelihood that that ever happens is close to zero. It's a good question. And
so is it one that requires more evidence, or is it one that is, you know, the frequent problem about the difficulties of doing research in pregnant women in the first trimester, and the drug companies being very careful in terms of how their drugs are used?
okay, is the drug company or WHO being careful?
Yes.
Yes.
Okay. Yes, Julie?
Can I add something, Rose?
Please.
So the MPAC met, I think now, I want to say 2 years ago, and the MPAC recommendation is actually to move forward with the use of ACTs in first trimester. And and that's published. You can see the output of the meeting on the WHO website if you go to the MIP section. My understanding is that the intent is going to be to include this recommendation in the first trimester in the next treatment guidelines, but that it's held up in some new internal processes at WHO, but that the hope is that it will eventually be released, allowing for the use of ACTs in first trimester. However, if you read the current WHO guidance, it actually states that if quinine is not readily available, that ACTs can be used. And so I think there is sort of an opening for countries to use ACTs in first trimester if that is the country's preference. So the data has all been summarized and compiled in the meeting report from the MPAC. And as Rose said, you know, there aren't randomized clinical trials, and so the numbers of exposed women, while large, are still, you know, not massive, but the data look very good.
Okay, thanks for that. Anthony Nuwa had another question, which I think we will ask Julie after your presentation. But there was another question from Mani Ahmed in Nigeria, and it was, how reliable is the RDT in detecting both falciparum and vivax species in early pregnancy?
That's a very good question, Mania. For once you start to try to detect vivax, because it presents with a lower parasitemia, the RDT sensitivity specificity falls off. So it's not parasite counts less than 100 per 500 with RDT for P. vivax are not very good. So our microscopists at SMRU will outperform the RDT for the low parasite vivax counts. But RDTs are reasonably good for falciparum, but your question also brings the other problem of the generally lower parasitemia seen in pregnant women, particularly in Africa. So testing is better than no testing. Okay?
Then, Rose, just following on your question about your point about underdosing in women, and what, from your experience and perspective, others who are involved in research or implementation, what's the lesson that you are learning? And obviously we should be worried, because not only do you get a lesser therapeutic efficacy, but also the opportunity for also sort of perpetuating drug resistance.
Yeah. It would be good to do a study, so if anyone out there is interested, 5 days coartem versus 3 days coartem in pregnancy with PK, to see if that improves the drug levels, drug concentrations. If that brings it up to the what we see in non-pregnant, equivalent concentrations in non-pregnant. When we give coartem, we must give it with fat. Every dose should be administered with fat, and pregnant women need to complete their course. But yes, we do need more PK studies.
Okay, thank you. Now moving on to the next presentation, which is on IPTp and MIP in Africa. Julie, over to you.
Thank you, James. So I'm going to be talking a little bit about IPTp and malaria in pregnancy in Africa. So next slide. Including the effectiveness of intermittent screening and treatment alternatives.
Julie, could you go closer to the mic? We can't hear you. Yep, thank you.
Sure. Alternatives to IPTp and a little bit about case management. Next slide. So I just wanted to briefly, next slide. Thanks. So I just briefly wanted to remind people of the burden of malaria in pregnancy in sub-Saharan Africa. It's been estimated that there are about 30 million pregnancies that occur in areas of Africa within the WHO Afra region that have transmission primarily of P. falciparum, but in some cases P. vivax. Overall, maternal mortality is about 10,000 deaths per year, with about 100,000 fetal deaths per year, and that's worldwide. There aren't specific African numbers, but it has been estimated that malaria in pregnancy is responsible for 20% of all stillbirths in Africa, so quite a substantial burden. Next slide. So I didn't feel like we could talk about ISTP without first giving a few words on IPTp. So as people know, IPTP involves giving a treatment dose of sulfadoxine pyrimethamine during the 2nd and 3rd trimesters of pregnancy. And that has been shown to reduce maternal anemia by 10%, placental malaria by 50%, low birth weight by about 30%, and infant mortality by about 18%. And recent review comparing 3 or more treatment doses with less than 3 treatment doses have found that providing additional doses in pregnancy reduces low birth weight with a relative risk reduction of 20% per dose. It reduces placental parasitemia with a relative risk reduction of 50%, nearly 50%, and severe maternal anemia with a relative risk reduction of 40% among post-gravid women. So next slide. So the issue of ISTP comes as a response to increasing concerns about resistance. So parasite resistance to SP develops as an ordered accumulation of point mutations in genes for folate synthesis, first in dihydrofolate reductase, and then in dihydroapterate synthetase. And the key mutations are the mutation at PF-DHPS 540, which is found in Eastern and Southern Africa, and this is the quintuple mutant. And that's been associated with significant treatment failure when treating children. However, as we'll see on the next slide, there is still some efficacy of IPTp in areas with the quintuple mutant. More concerning is the addition of a 6th mutation at codon 581 with A581G that's been associated with an even greater level of resistance, and this is referred to as the sextuple mutant. And at present, high-level SP resistance with sextuple mutant is restricted to relatively small areas in the areas shown in red on the map. So at the corner of Tanzania, Rwanda, there, and in Tanga region in Tanzania. And in these areas where you have more than 37% prevalence of the sextuple mutant, it's been found that IPTp-SP is likely not effective. So next slide. So this shows the data on IPTp efficacy in areas with SP resistance. And in the small graph, you can see the green line that the adjusted relative risk of low birth weight is actually very similar across the spectrum of resistance, although there is some evidence of a decreasing efficacy as resistance increases, up until the point where you have the highly resistant sextuple mutant shown in red. And in those areas, you can see that there is almost no efficacy of IPTp-SP. And that's called the super resistant mutants. So thank you, next slide. So as a response to the concerns of increasing resistance, there have been several trials looking at intermittent screening with RDTs and treatment in pregnancy, or ISTP. There have been 4 trials so far, 2 in West Africa, 2 in East Africa, and actually an additional trial in Nigeria, which was not included in the review that I will show. And these failed to show that ISTP was superior to IPTp for prevention of low birth weight, maternal anemia, or placental malaria. ISTP overall is associated with a higher incidence of clinical malaria episodes than IPTp-SP and has not been found to be cost-effective compared to IPTp-SP. So next slide. So this shows meta-analysis looking at intermittent screening and treatment with an ACT as compared to IPTp-SP. And what you can see is that although in general, the relative risk is relatively close, that in the East African trials where there is more resistance to SP and you would expect that intermittent screening would actually be preferable to intermittent preventive treatment, we actually found the opposite, and that IPTp with SP is preferable to ISTP. And in the overall analysis, this held true. Next slide. And similarly, when you look at ISTP with an ACT compared to IPTp with SP for prevention of low birth weight, in all of the trials thus far, we find that IPTP improves birth weight more so than ISTP. Based on an unpublished analysis that's in progress, a mediation analysis was done, and several studies have suggested that there are some antibacterial or other effects of SP that are contributing to the increased birth weight. And this appears to be the case using modeling studies. So although using an ACT results in a greater clearance of the malaria, the non-malaria effects of SP outweigh the effects, the antimalarial effects of DP. So what this suggests is that in order to achieve the maximum benefit for women, we might need to consider combining a drug like DP with another antibacterial treatment. So next slide. So essentially, at the present time, WHO does not recommend ISTP at all. In the meanwhile, looking at alternatives for IPTp, studies have looked at mefloquine, chloroquine azithromycin, amidiaquine, and dihydroartemisinin and piperacin. So the trials of low-dose mefloquine in 4 African countries have shown high efficacy against placental and clinical malaria, as well as hospital admissions, but there was not an enhanced effect on birth outcomes compared to sulfadoxine pyrimethamine. And due to very poor tolerability of mefloquine, this has been discarded as a potential option for IPTp. A large trial of chloroquine azithromycin was actually stopped early as a result of inefficacy of chloroquine azithromycin compared to IPTp-SP. And high dose of SP plus azithromycin is very poorly tolerated. There has been a study looking at lower doses of azithromycin where women received 2 courses of 1 gram per course, and that showed better tolerance with some reduced risk of low birth weight. But despite that, at present, azithromycin is not being recommended, although it is currently being looked at in an ongoing trial. IPTp with amidiaquine has also been shown to be very poorly tolerated and has been abandoned for that reason. So that leaves us with dihydroartemisinin and piperacin, which at present is the most promising option to replace SP in areas of high resistance. So next slide. There have been 2 studies in HIV negative women that have been completed and published, looking at 500 women per arm in Kenya and 100 women per arm in Uganda. And overall, found that DP reduced malaria at delivery and clinical malaria during pregnancy. However, there was not a significant impact on composite newborn morbidity that included low birth weight, small for gestational age, and preterm delivery, although other perinatal outcomes were improved. So next slide. This shows meta-analysis of these studies. And you can see that in terms of clinical malaria, peripheral malaria at delivery, and placental malaria by histology, IPTp with DP far outperformed IPTp with SP. However, when we were looking at the actual fetal outcomes, which is what IPTp with SP was initially implemented to prevent, there is a much smaller evidence of benefit with a much higher cost of DP. So for that reason, WHO recommended doing additional studies to confirm the findings before they would make any further policy decisions regarding the use of IPTp-DP widely throughout sub-Saharan Africa. So moving on to case management of pregnancy. So maybe one more word on IPTp. As I mentioned, there is a very large trial ongoing in Tanzania, Kenya, and Malawi, looking at IPTp with DP alone or in combination with azithromycin compared to IPTp-SP. And that is expected to provide additional data to inform a recommendation for WHO in the relatively near future. Okay, so case management, next slide. So as we mentioned, next slide. The case management of malaria in pregnancy, as we all know, is trimester dependent. And in the first trimester, quinine with or without clindamycin is preferred. because of the limited data on the safety of artemisinin in the first trimester. However, WHO does recommend that if quinine is unavailable, ACTs should be used. In the second and third trimester, ACTs are preferred over quinine plus clindamycin. Regarding the question about who should be screened, definitely any pregnant woman with fever or other symptoms should be screened with a test. But there is some question that in areas of high level of SP resistance, screening all women at first antenatal care may be of benefit. This is based on the data from trials looking at intermittent screening and treatment, which show a relatively high efficacy of RDTs at initial presentation. So the efficacy of the RDT is in the range of 80% in primigravidae and about 70% in multigravidae if screened on the initial visit. However, the sensitivity of the RDT drops substantially after the initial screening. So it's been postulated that one possible means of addressing resistance until we have another option would be to add screening onto IPTp as a way to better detect malaria in pregnant women and treat them with an ACT while giving SP to women who have a negative RDT. There's also some data looking at using screening of women at their first antenatal visit as a form of surveillance, which could provide data not only on burden among pregnant women, but can also give a clue as to the general level of malaria in a community. An additional word on the safety of antimalarials in first trimester. So as was noted, there's been a meta-analysis of 7 prospective observational studies. There are no randomized controlled studies on this topic. And these combined total data from over 30,000 pregnancies. In total, there were 743 ACT exposures and 949 quinine exposures during the first trimester. And looking at this data in first trimester, there was no difference in the risk of miscarriage or stillbirth if women got quinine versus ACTs. And there was similar prevalence of major congenital malformations. So there was enough data to exclude, I believe, a 3-fold increase in risk. So more data would be needed to exclude a smaller risk, increased risk of malformations. Based on this data, the MPAC, as I mentioned, has recommended that ACTs be used in the first trimester, but we are still waiting for WHO to actually update the treatment guidelines to reflect this recommendation from the MPAC. That's the end of my presentation. So I'm happy to answer any questions. Thank you.
Thank you very much, Julie. We'll just take a couple of questions and then take a few more after Craig has given his. Francois has a couple of questions. He said, the evidence is already out there showing that the risk-benefit analysis in the favor of artemisinin in the first trimester, and linked to that, he says, in prevention is the poor efficacy of IPTp with dihydroartemisinin piperacin not due to the dose regimen. To be efficacious, DP needs to be given more frequently than 2 or 3 times during pregnancy. I don't know whether, Julie, you want to react to that?
Sure. So I think that as I mentioned, I think that there is a combination effect. So yes, DP given more frequently is likely to be more effective in preventing malaria. However, there is still the issue of the other non-antimalarial effects of SP, which we do feel like are still contributing to the efficacy of SP. And so there is a study looking at monthly DP, but it looked at monthly DP compared to 3 doses of SP, and that was the Uganda study. So it's a bit hard to really fully appreciate what the issues are. The ongoing study is looking at monthly dosing. And as I suspect that monthly dosing will be better, but I suspect that if you don't give some sort of replacement antibacterial, that you're still likely not to achieve the full potential. So perhaps a combination of DP plus SP or DP plus azithromycin or some other antibacterial might be better. Then of course you get into the realm of needing to weigh the risk of antibacterial resistance with the use of an antibacterial during pregnancy. And so WHO was very concerned about giving azithromycin frequently during pregnancy. And so, you know, a regimen that uses azithromycin is likely to only give a couple of doses of azithromycin during the course of pregnancy with a greater number of doses of DP. So that's what's being used in the current trial. And there's already data published that azithromycin given 2 courses in pregnancy improves birth outcomes. So, so I think at this point, you know, we don't fully understand all of the mechanisms through which IPTp-SP is working. It is certainly in part due to antimalarial, but it's likely that there is a substantial non-antimalarial effect as well.
Okay, and then Dario Scaramuzzi says, in one of the last recommendations, WHO proposed to assess a strategy based on SSTP at first ANC, followed by IPTp. So his question was, what is your opinion on this strategy? And then after you answer that, Rose, you have a comment, you typed in a comment, you may want to say something about that. But first, Julie, and then we go on to the next. Okay.
Yeah, so, you know, I think the issue with SSTP and in general, the issue with testing the efficacy of treatments in pregnant women is that when you're looking at the impact on birth outcomes, you need very, very large sample sizes to really find a large difference. And as malaria control improves and there is generally less malaria, and women are hopefully being treated better, the issue of testing the efficacy of SSTP is going to require a massive sample size if you're looking at SSTP plus IPTp-SP. I personally, based on the modeling data and what we know about malaria and how harmful malaria is in the first trimester, I personally think it is likely to be of benefit to women, but you might need a very, very, very large study in order to be able to prove that. So I think that that study should be done, but we need to find funding for it. As I mentioned, it's possible that we might get countries to take up a practice of SSTP based on using that data for surveillance. So without having data on the efficacy to the individual pregnant women, I think one can make an argument at this point to use data from pregnant women for surveillance purposes, and then you have the added benefit of providing that service to the pregnant woman herself. So I'm sure Rosa, I'm sure has thoughts because they do much more screening.
Yes, Rose, you had a comment? Rose, you need to unmute your mic, sorry.
Thank you. We have no choice except to screen. We have no drug for prevention for decades. So we work on quality control to do good screening. We don't use RDT because we cannot catch the low level parasitemia. We will use RDT in outpatients, but not on pregnant women. We use microscopy. So yeah, so we have no choice except to screen. And then I did have two, thanks for the presentation, Julia, it was very clear. I have two remarks. Mefequin's a very good drug. We used it as a combination ACT for more than 20 years. We used it for tropical splenomegaly syndrome, and the original trials on mefloquine for prevention of malaria in pregnancy were done on the border until we lost use of mefloquine monotherapy. So it was never introduced, but it did very well as a preventive in pregnancy. And the MIP consortium, when we give it for prophylaxis, we give 5 milligrams per kilogram. And when the MIP consortium treated healthy pregnant women with 10 and 15 milligrams per kilogram, there was a lot of side effects. So it's like mefloquine's got a really bad rap because the dosing used was not optimal for prevention. So I don't think we should give up on mefloquine. And the second remark is that WHO says, or you pointed out that WHO says there's not enough data on ACTs in first trimester, and so we should still use quinine. But honestly, how much data is there on quinine in first trimester? Not enough, and not much more. They're very, very similar in the amount of data we have. And yeah. ACT looks more favorable. Thanks.
Yeah, no, if I can comment, so the one is sort of the official, what's in the current treatment guidelines, but as I said, I agree. I think that, you know, WHO needs to get the updated treatment guidelines published, allowing use of ACTs in first trimester, and sovereign countries can review the data and can make their own determination using the published data and the review from the MPAC. So there's certainly a window for countries to move forward with treatment in first trimester with ACTs, given the current recommendations saying that that ACTs can be used when quinine is not available. So if you make quinine not available, then you have to use ACTs in first trimester.
Yes, I think thanks for that comment, Julie. And countries that are sort of writing their proposals for the next Global Fund rounds, I think, yeah, we'll have to think about those issues. Thank you very much, Julie and Rose, for your comments, the presentation, and all the questions that are coming. As usual, time is always not on our side. I'll now like to move to the next presentation, which is by Craig, and he's going to say a little bit about IPTp in HIV-positive mothers. I think he's going to be raising a couple of the issues that we need to consider. Over to you, Craig.
Okay, thank you, James. So, yeah, I mean, this presentation is, in a way, it's more sort of a long-winded set of questions, really, to take advantage of the fact that Julie and Rose are online. So what I'll be talking a little bit about is just sort of malaria in pregnancy amongst HIV-positive mothers, and how prevention and IPTp is perhaps slightly different in different set of circumstances. So IPTp-SP is normally what's provided in high transmission areas to prevent malaria in pregnancy, but there are a group, or depending on location, a subset of HIV-positive mothers which have a CD4 count low enough, or clinical disease stage of AIDS high enough, that they're not eligible to be taking IPTp-SP, and they should be on a daily dose of cotrimoxazole to prevent opportunistic infections during pregnancy. There are also recommendations in areas where there are high levels of malaria and high levels of other infectious disease, where regardless of CD4 count and regardless of disease, cotrimoxazole should be taken to prevent opportunistic infections, but it is listed as a prevention of opportunistic infections, and sort of the preventing malaria is sort of seen as an additional advantage. There is quite a bit of data to show that cotrimoxazole is not inferior to IPTp-SP as a means of prophylaxis during pregnancy. Concomitant use of SP and cotrimoxazole is contraindicated because of similar actions. But as we're thinking about this, as we've heard from Rose and Julie, SP resistance is significant, and other IPTp alternatives are being explored. You know, is cotrimoxazole something that we should be looking at? And as has already been mentioned, IPTp-SP is normally associated with reducing low birth weight outcomes. And also just to say that HIV-infected women are at a much higher risk of clinical and placental malaria. So having a sensible means of prevention is incredibly important. One other point as we talk about IPTp is that often the way that the data seems to be presented is that you have IPTp is presented as purely those women who are receiving SP during pregnancy. But in reality, in areas where there might be a large proportion of HIV positive mothers who are taking cotrimoxazole, they seem to be sort of missing from global indicators on people that are actually taking acceptable prophylaxis during pregnancy. So this is something that we really need to consider when we're looking at global indicators of people that are on acceptable prophylaxis during pregnancy. Also just, I'll move through this relatively quickly because I don't want to repeat too much of what Julie and Rose have already said. But SP prophylaxis really assumes some level of prior immunity when we're thinking about resistance. And Julie had mentioned sort of quintuple mutants for SP resistance. But in the event, if we have areas where we have high resistance and we have changing transmission dynamics, and you have populations which are losing their innate immunity, would it make sense to investigate further the benefits of cotrimoxazole also in HIV negative pregnancies as well? Is that a sensible thing that we should be looking at? There is also some evidence that among sextuple mutants in East Africa, as Julie was mentioning, with a pool prevalence estimate of about 37%, that there's no protection of low birth weight, which is one of the main advantages and one of the main reasons for providing SP during pregnancy. Would it make sense to consider cotrimoxazole as a possible acceptable IPTp, not just among the HIV positive population, but also amongst an HIV negative population? There is also some evidence in the literature contrary to what might be expected when we think about administering cotrimoxazole, and that is that there are a few trials which have shown that the use of cotrimoxazole does not actually select for SP resistance, but actually could have the converse effect. So I've been reading quite a bit about, is there a negative antagonistic selection pressure there, despite the fact you might think the contrary might be true. And also then just to reiterate, again, what Rose has been talking about with asymptomatic malaria infection, when we think about high levels of SP resistance, what doses are curative, and not just sort of what cumulative number of SP doses now need to be given in areas where we have high levels of SP resistance in East Africa to actually be curing people during pregnancy of malaria that's not going to be detected through RDT, and often in areas with not with particularly good microscopy, or perhaps unlikely to even be detected through microscopy. So just to sort of stimulate the discussion, so what are the solutions, or what are some of the questions that we should be asking, sort of considering these points? I think that IPTp-SP indicators, or IPTp indicators in general, should consider non-eligible women on acceptable prophylaxis, and we should be looking at sort of national protocols and really taking that into consideration when we think about how many women who are pregnant are on acceptable prophylaxis. Are there opportunities for alternative IPTPs? Sort of as was mentioned, does cotrimoxazole have a place for IPTp in HIV negative people? And if there is sort of antagonistic selection pressure as we change drugs, would it make sense to have, as has happened with curative drugs before, would it make sense to have IPTp drug rotations in certain places to slow down the pace of resistance? I think also there is a place for studies in parasite clearance of asymptomatic infections to be conducted, again, looking at HIV positive people and HIV negative that are undergoing cotrimoxazole and, IPTp-SP. And I think really one thing that has struck me over the years working across Asia and Africa is that I think there's an opportunity to look at HIV, malaria, co-infection across areas where we have high prevalences of malaria, but there doesn't seem to be a great deal of crosstalk or sort of conversation between HIV specialists and malaria specialists. And I think for that reason, there are perhaps opportunities there, research opportunities which are being missed. And I think that there has to be sort of a greater level of communication between those groups of people on IPTp. So again, as I said, for me, this is more sort of just putting out a few ideas to stimulate discussion while we have Julie and Rose on the line. So if there's anything from these points that you think might be worth commenting on, then please do.
Okay, that was sort of to be more thought-provoking than to sort of present data. I don't know if there's any immediate reaction from the panelists, and then just maybe one or two questions, and then we go to Anthony Nuwa.
And pregnant women need good protection, and pregnant women with HIV need even better protection. So at the moment, with our current policy, we're failing them. And we're failing not just, I like your point, Craig, about collaboration. We're failing not just on SP and COTRI, we're failing on ANC, the number of ANC visits. So we've moved on from ANC 4. WHO now recommends 8. Many countries are still promoting how happy they are when they have ANC 1. So ANC 1's never going to get us the number of SP doses we need, or the number of, even ANC 4 isn't going to give you your monthly SP that you need for women with HIV. So yes, collaborating, working with these HIV specialists, combining efforts, because all of these studies are so expensive, is a very good point. We used COTRI after the loss of ampicillin and amoxi for urinary tract infection in pregnancy. We switched to COTRI, and we lost that within about 5 years of use. So COTRI doesn't come without additional complications for other bacteria. Any antibiotic that we use is going to have knock-on effects on our microbiome, which we now know affects the newborn. May not be measured by low birth weight, may be measured by other things later in life. So yeah, we need to think about what we're doing and what drugs we give. So yes, combined consortium sounds good. Thank you.
Okay.
Yeah, I just want to very quickly echo, I completely agree with Rose. And I agree, for the most part with these the issue of IPTp SP, that, you know, we need to do a better job of identifying the non-eligible women, or women maybe who receive treatment instead of SP, and they, you know, did receive something, so that they're not counted as having received nothing. That there really is a substantial need to find alternate regimens for pregnant women with HIV that are more efficacious than cotrimoxazole. I would not consider the use of cotrimoxazole in HIV negative pregnant women, though.
Okay. All right. Moving on. Thank you very much, Craig. We'll take some questions close to the end. I just don't want to run out of time. Anthony Nuwa, are you ready to make your presentation? Hello, Anthony?
Yes, hello.
Yes, please, go ahead.
Okay, next slide. I just want to introduce our case study that we did under a DFID-funded project in Uganda called Strengthening Uganda's Response on Malaria, that is running in 27 districts, northern Uganda. Next slide, please. Majorly, this introduction has been talked about. We know that malaria and pregnancies produces a lot of burden, public health burden. More than 30 million pregnant women each year. Endemic areas affected by this. And where we live, that is in Uganda, majority of these women are asymptomatic, and Rose had talked about this already. What we know that pregnant women get more severe cases of malaria than the non-pregnant, and the MIP causes more of those conditions in severe anemia, low birth weight, preterm deliveries, and other complications, and of course neonatal and maternal death. Next. Next slide, please. Exactly, for the sake of this, of the project, or SUMA project, as you can see, it's a 5-year project funded by DFID. Malaria Consortium is implementing it in northern Uganda, and the colored districts is where this project is running. However, we started with the district, the green ones and the purple ones. We have just gone to the Karamoja sub-region, which is a bit that brownish, light brown color district. And it is it's a 5-year funded by, we are working in collaboration with UNICEF. Funds from DFID go through UNICEF for us, we're implementers, and we are working with the district health systems. Go on. It has all areas of malaria, prevention, control, and treatment. It works at, we are looking at the health facility level, and then at the community level. We're actually working with around 25 village health team members, which are the community health workers, and they are treating malaria, pneumonia, and diarrhea. For the case at the facility level, we have all components of malaria again, but for this project, we realized that we need to introduce something that is not being introduced somewhere else, and thus we realized that mothers have this area has, it is highly endemic. Northern Uganda has the highest malaria burden in Uganda, and the Karamoja, of course. And we know that when we did the baseline survey, we realized that pregnant women had more malaria than the non-pregnant, and so we decided that. And when we did health facility assessment, we realized that when mothers go for antenatal care, they are referred to be, after assessment, even given SP, then they are referred to go and do the testing. So we found that there's a gap. The gap is that the first screen them. Some of them don't feel any symptom because they are asymptomatic, and then they are referred to go and line up because you find the facility has long lines in antenatal. So a mother takes a lot, maybe 1 hour in antenatal, then she has to go again line up for the lab testing or an outpatient for testing. So majority of them, since they are not feeling malaria, any fever, they just go away. And then, so there's a missed opportunity to treat these mothers. And then we don't know what happens, but we have been here getting, of course, underweight. We have not done a study to show whether those ones have come back with those symptoms, these problems of the preterm babies, and then. But we under this study, under this project, we decided. Please next slide. We decided that we do something that is in line with the World Health Organization recommendation of focused ANC, which involves screening all mothers for malaria, especially in endemic countries. And therefore, we introduced what we call RDT corners in antenatal care units. So health facilities, we selected all health facilities with ANC. We trained health workers, and then on how to do, the midwives on how to do MRDT. We set up MRDT corners in these units, and then because we had to work with in charges of the facilities, and then the district health team, make sure that at least they allocate some MRDTs for these corners, because this is a new area. It's a very gray area in our policy. No one is. So this is the first time we are doing this in Uganda. Next slide. So this is more of the first results coming out. As you can see, we have been in 75. We have only selected 75 health facilities. It is in around 358 facilities where we have introduced these corners. But I only selected 75 facilities for the sake of this presentation. We are still collecting more data. As we tested for Acholi sub-region, where we had 30 facilities. Over a period of 8 months, we tested 51,000 mothers in ANC, and the 28,000 of them were positive, giving us a positivity rate of 54%. Lango sub-region, 15,000 were tested, 7,000 were positive, 49%. In total, we've tested 67,000, and then over 35,000 were positive, giving us a positivity rate of 57%, which these results, next slide, shows that we should have done it earlier. First of all, some of these mothers go and they come back with malaria, like Craig asked, when we give them SP and they are asymptomatic, what happens? Is it acting as a treatment or is acting as a preventive measure? No wonder when you increase the level, the doses of IPTp, you're moving over almost from prophylaxis to treatment mode, and that's why you get the better outcomes. Could be the reason for that is giving us that. So the malaria in pregnancy is a big problem in this setting, and therefore, and also what we found that needs to be worked on, and it has been a policy that midwives have a lot of workload. They don't consider testing for malaria as a priority as they do for HIV. Then the attitude of health workers at NC clinics affect the testing rate. Some health workers still push, they refer the mothers to OPD for testing. Again, next slide. Next slide, please. So we had some key learnings. The slide before, we had some key learnings. that MRDT corners are feasible, acceptable, and encourage mothers to test, especially those ones with the symptomatic ones. And then, but we also learned that there are low stock levels of MRDTs, and therefore in charges don't prioritize the stocking the NC department. So we tried to convince them, but majority of them prefer to test to do the testing in OPD rather than putting the corner the other side, because they think mothers can still join the other side, but majority of them don't actually come for NC. Next slide. So our recommendations, this is just a preliminary, we've just started. As I said, this is just 8 months down the road. We want to continue lobbying and orienting health workers, especially the in-charges and midwives, on malaria and pregnancy, which they don't really, when you talk about malaria and pregnancy, many of them, they jump to IPTp. They don't know that this is more of a case management issue. And then in terms of stock and testing, putting stuff, testing corners, encouraging mothers to go for test even if you don't have the test corner in the lab. And then we also think that it will include this approach and guidelines in the new policy that we are working on, especially to be in line with the World Health Organization focused ANC. We want to improve and sustain the coverage of MIP prevention and interventions. We want to build the same I know it is happening in the private sector. So we want to make sure that whatever we're doing in the public sector should be in the private sector, and we want to integrate MIP intervention into existing service delivery approaches at the community level. Whatever is happening can be replicated at other levels. Next. So those are a few references that I looked at. Thank you.
Thank you very much, Anthony, for that case study from an operational setting that brings to life some of these challenges that we have been highlighting in the presentations. I think there are a couple of questions that are coming from the panelists. I'll just really ask, and then whoever has the answers. This is somebody called Galaxy that says, I recently finished a project on the uptake of PMTC services by HIV positive mothers accessing care in Nigeria, and discovered many HIV infected pregnant women still face constraints in accessing ARV drugs, either because they refuse to cooperate or are lost to follow up in the existing programs. Is there any strategy in place that can be used to increase the uptake level? I think that's sort of a fairly general question.
Yeah.
Which I don't know, Craig, whether you want to start thinking about that. And then another question was that, let me see. Oh, there was something along the screening studies. In the screening studies, how frequently are the patients screened and with what? I think this is specifically with regard to which type of RDT. Okay, yes. Let me just put those out there, and then any of the panelists who wants to comment.
Okay. If it is coming to me, okay, I'm trying to reduce the. So what we are doing here, we are using the government team RDTs. They are procuring SD Biolen, but sometimes they also procure Caster. So whatever they are preparing is what we are using. And then how often we do it from, as long as the mother comes for antenatal, the first ANC, but when even goes back, because we can go back and contract the malaria. But what we think is, and remember, these mothers come, first of all, they come late. Secondly, they don't come every week. So there's no fear for finding the persistent antigen. That's what we are picking. And two, maybe since this is the beginning, we hope when the policy takes it up, we shall have, maybe going forward, we shall have also laboratory corners if they are, and they have microscopy. Microscopy is there, but this is more of something that we are beginning on. Just started.
Okay, and there's a question which I think is going in the chat. Is there any report available showing the side effect of cotrimoxazole in HIV negative or women connected with malaria? If yes, what's the possible solution to this? And I think Rose has provided some sort of a response. I don't know if anyone wants to take that on. Rose, yeah.
Rose, I think if you want to go ahead.
Right, I'd be happy if someone else took it because we have a low rate of HIV. Only that, the only...
Rose said in non-pregnant adults, daily cotrimoxazole prevents malaria and reduced incidence of antifolate resistance, P. falciparum, but contributed to increased pneumococcus and commensal Escherichia coli resistance. And she's put the reference. Okay, just want to, if there are no other burning questions, I know.
Yeah, I have a short question for Anthony, please.
Try our best to send you some answers to those questions. We will do a write-up summary of the webinar, and we'll publish that on our website. And we will.
James, there's a question for me
as well for those who will want the recording. So just to say thank you, everybody. We know that this is a major problem, and it's Rose, you said we have let down pregnant women out there who deserve better and who need better prevention, better case management, as well as the children who are being exposed to parasites at the time when they're so vulnerable and are developing. So this is something which I hope we can do better. And as WHO changes some of its recommendations and funding becomes more available through channels such as the Global Fund, PMI, that we can do better going forward. Thank you very much for all your time and participation, and looking forward to the continued collaboration. Bye-bye from the Malaria Consortium.
Thank you.
Thank you.
Thank you.
for me.
I'll send you, Anthony, directly.